Dr. Kevin Stucki completed undergraduate studies at Idaho State University, received a Doctor of Osteopathic Medicine degree from Des Moines, Iowa, or Des Moines University, completed an internship and orthopedic surgery residency at Lake Erie College of Osteopathic Medicine, and a hand and microvascular surgery fellowship at the University of Utah. He also received specialized training in the treatment of hand, elbow, and shoulder conditions. He treats microvascular conditions and has completed extensive surgical cases in pediatric orthopedics. Dr. Stucki is a candidate member of the American Society for Surgery of the Hand, as well as an active member of the American Osteopathic Board of Orthopedic Surgery and American Osteopathic Association. Dr. Stucki was born in Provo and grew up near Idaho Falls. He enjoys spending time with his wife and 4 children while camping, hiking, and fishing. His hobbies include running, biking, boating, snowboarding, and playing basketball. It's a wonder he gets to work at all. And so for our last session this morning, I'd like to introduce to you Kevin, who will be talking about hand surgery.
Very good. Well, thank you for having me. It's good to be here. I appreciate the opportunity to talk to you. And I've kind of taken an approach today trying to identify some of the things in the literature with respect to hand surgery that might be fairly common and that might give you some ideas of how you can educate your patients. I will indicate that a lot of the studies that I've reviewed are not studies that were done in 2009 or 2008, but you may see some in 2005. I reviewed the last about 5 years of the literature with respect to things that are new in hand surgery, and I think you really have to define what new really means, because a lot of things, at least in hand surgery, I'm sure in other fields, new can mean a lot of different things. New can mean that we're just now being able to use it, and new can mean that it's something that is new and is in the framework of an idea and is being studied and used. And you'll see both of those in the talk today, things that maybe we're not using yet because they're not available to us, but are new ideas that we're looking forward to, and also some new things that, scaphoid fractures certainly aren't new, but there's some treatment things and controversies that have hopefully been had some light shed on them for our day-to-day. So the idea today is to kind of review the literature, obviously not all of it, but some specific topics in the literature that might be interesting to you, and then identify the current concepts with the treatment of those issues. And then I'll provide a brief commentary and maybe even my own opinion about some of those things and some of the articles that have been provided. So first of all, something that we probably have all seen is scaphoid fractures. And I reviewed a couple of articles with respect to scaphoid fractures because scaphoid fractures have been treated a lot of different ways over the years. And we do pretty good at treating scaphoid fractures in just a cast for the most part. The thing that is important to understand, the scaphoid fractures can come in a lot of varieties. You can have distal pole fractures, you can have waist fractures, you can have proximal pole fractures. The fracture can be transverse, it can be oblique, it can be a lot of things. So when you review these papers, you have to be very careful because oftentimes they don't tell you exactly what class of fractures they're treating. So in this study, they're looking at a technique that we use for non-unions, so fractures that have gone on to not heal. And we know that those fractures are more commonly found in the proximal pole of the scaphoid. We know that those are more common in smokers and more common in patients that have displacement. And this is a technique where we take a piece of bone from the distal radius. There's a small artery there, and I won't try to pronounce that for you multiple times because it gets tongue-tying, but you leave that artery attached to that piece of bone, and then you transfer it over into the scaphoid. You reduce the scaphoid non-union, and then in the past they've put pins or screws across that area. And this study sort of looked at what are the things that cause this procedure to fail. Why does it fail? And one of the things that they found that caused it to fail was fixation. They noticed that the graft could displace, and the graft would usually displace with pin placement. And so typically, because of this article and other articles, we don't typically use pins anymore. We use a new screw that has been developed, and there's a lot of companies that make this type of screw, but it's sort of a cone-shaped screw that allows, as it goes in, the pitch changes and causes the fracture to be drawn together. And that also draws the fracture around the pedicalized graft that you put in, and has reduced the number of continued non-unions or the failure of this procedure. What also came out of this study was that they showed that, again, they confirmed that patients that failed this procedure, even those that had screw fixation, typically were patients who continued to smoke, patients that had significant humpback deformity. That means that when the fracture was fractured, it was displaced, and the scaphoid is sort of a bean-shaped bone, and when it fractures, part of it bends one way and part of it bends the other way, and it kind of forms a U shape or a humpback. And those that had the humpback deformity that was not corrected, that had failure of this as well. And then for some reason, and we don't know exactly why, but male patients tend to fail this more often. They're also the ones that get it more often. So a couple of neat things came out of that, and new ideas that have helped us in the treatment of scaphoid fractures. Again, we're going to continue on with scaphoid fractures for a little bit, because there's been a couple of things. Again, there's been a controversy with these new screws that we've developed. They're very easy to place. We can make maybe even less than a centimeter incision on the dorsum of the wrist, or even on the volar portion of the wrist, depending on how you want to put it in, and place this over a guide wire with very little dissection. And so the surgeries become very easy, especially for non-displaced fractures. But the question is, why do we need to treat non-displaced fractures with these screws? And a while back, hand surgeons were making an argument about using screw fixation, because they thought if you can avoid being in a cast and go back to work, then we might decrease the morbidity that these patients experience with cast immobilization. Cast immobilization for scaphoid fractures can take anywhere from 8 to 14 weeks. And so if you can imagine, as a physician or even a surgeon, having a scaphoid fracture and I think to myself, if I had to be in a cast for 14 weeks, that would really dramatically affect how I functioned in my practice. And so for me, if I had a scaphoid fracture, even if it was non-displaced, personally, I would want to have it fixed so that I could continue, because in a week I'd be able to operate again. Whereas if I had a cast, I couldn't do that. And so there has been a controversy with that. Can we increase the return to work in patients that have non-displaced scaphoid fractures? So there's been a couple of studies that have looked at that, and this particular study looked at it and showed that patients that were placed in a cast and patients that were placed in a scaphoid had very little, no significant difference in their return to work. Again, the difficulty that I have with this study is the fact that they don't talk about the specifics of the fracture. They say non-displaced fractures, but in some of the classification systems, non-displaced fractures can also be unstable fractures. So these fractures can displace later and be an issue and cause non-union. And so this particular study said there's really no difference, there's really no benefit in treating patients with scaphoid fractures that are non-displaced with surgery. Again, my own personal opinion on that, if it was me, I would probably have mine fixed just so that I could get back to work, because I know that I would. Whereas if I had to be in a cast for 14 weeks, it would just be impossible. So that's something that we have to take into consideration. But again, you have to think about, is it a displaced fracture, is it a stable fracture, or an unstable fracture? Again, this study looks at a similar thing, and they looked at, again, immobilization versus screw fixation. But they were more specific in this study, and they looked at actually unstable fractures. So there's a classification called the Herbert classification. It's A, B, C, and then there's 1, 2, 3 in the Bs. And basically, you have a situation where they are now looking at a fracture that is unstable. This may be a waist fracture, but it may be in an oblique fashion that later can turn into a humpback deformity or displace. And in their study, they showed that the group that was casted had a higher risk of having non-unions later because of displacement. And so what I really have taken kind of out of these two studies is that, yes, we can treat scaphoid fractures in cast immobilization, and we probably should treat them in cast immobilization. However, we need to be careful to identify the specific classification of fractures that we're using, and that means if it's a stable fracture that is non-displaced, it should be treated in a cast, except in that small majority of patients that may need to be more active sooner. Even though that one study said that there was no difference, I have a hard time believing that I wouldn't get back to work sooner without a cast on. This looks at, again, the percutaneous screw fixation. They were looking at fractures that were unstable. They showed, again, a similar thing with this percutaneous technique, that we can fix these fractures with limited morbidity and have better results than those that are in casts when they are unstable. Now, there can be more risks with surgery, obviously, but this percutaneous technique, there are very little risks associated with it because the incision is so small. The biggest risk, in my opinion, is the length of screw, and that's probably the thing that I see the most commonly done incorrectly, is that the screw is placed, that the scaphoid is flexed in the wrist. So if you have the wrist held up like this, the wrist looks like this. If you take an AP film of that, the scaphoid is slightly flexed. Your screw may look like it only goes to the tip of the scaphoid, whereas if you actually bend the wrist up and get a plain view of just the scaphoid, your screw is now long into the scaphotrapezial joint, and now you put them at risk of having scaphotrapezial arthritis. And that's probably the most common complication that I see as a result of that, is failure to get the right length of screw. You can also look at that on a lateral, and that will help you to identify the length of your screw. So let's move on from scaphoid fractures and look at nail bed injuries. This is one of the biggest things that plagues hand surgeons in the ERs because they're very common. Fingertip injuries are very common, and nail bed injuries can have dramatic effects for patients if they're not repaired appropriately. However, they can take some time. So this study looked at the use of Dermabond for the repair of nail bed injuries. Typically, we use like a 6-0 chromic or a 6-0 vicryl to repair these injuries, and they can take anywhere from 25 minutes to an hour, depending on the extent of the injury to the nail bed. And this study looked at using Dermabond to repair the nail beds instead of suture technique, and looked at the time that it did to do that. And they also looked out to see how these patients did long term, whether using this was compromising the care that we were providing the patient. There was no difference in the appearance of the nail, the patient's function, their comfort, and how pleased they were with their result, whether they had suture repair or whether they had Dermabond repair of the nail bed. However, for the surgeon, the time that it took to do it was 9 minutes with the Dermabond and an average of 26 minutes with suture repair. So it's an exciting thing for hand surgeons to have something like this, or maybe even ER doctors that do some of this, because this can significantly decrease the amount of time that you have to spend with these patients and taking care of them, and it's certainly an appropriate way to take care of it. Now, again, the thing that they didn't indicate in this study that I think is one of the problems with this study is they didn't talk about what types of nail bed injuries there were. If you have a simple laceration of the nail bed, that's fairly easy to repair with Dermabond glue. However, if you have a stellate type injury to the nail bed, that's going to be much more difficult to get a good repair, I think, with just the glue. So you have to consider those and some more studies. Again, classifying these specific injuries will be better. If you take all comers in a study like this, then your results are going to be skewed because you don't have the same injury. Trigger finger, something that we all see, but trigger finger specifically in diabetic patients. This study looked at a new technique used for treating trigger finger. Now, obviously, as you know, we treat trigger finger a lot of different ways. There's injections, there's splints that we can use. There's now a new technique, which I didn't review in this study, but percutaneous release of the A1 pulley. Those are all good techniques that can be used for the treatment of this. But in diabetics, we commonly see recurrence, even after surgical release of the A1 pulley to relieve their trigger thumb or trigger finger. We commonly see recurrence. And the reason why we see recurrences is because typically in nodular trigger finger, which means that there's a nodule that develops in the tendon that is triggering past or through the pulley. In diabetic trigger finger, what happens is the whole tendon becomes thick and edematous. And if you look at the anatomy of the tendons, at least to the fingers, not so much the thumb, but to the other fingers, all the other fingers have two tendons that go to them, flexor digitorum profundus and a flexor digitorum superficialis. And as the profundus comes, it inserts distally on the distal phalanx, whereas the superficialis inserts on the middle phalanx. And as those tendons pass each other, the digitorum profundus actually goes through the center of the superficialis. And then that tendon, the superficialis, comes around and connects again and inserts on the base of the middle phalanx. So we actually have two areas where we can have that triggering occur. Now there's obviously multiple pulleys through the finger, but these seem to be the most important areas. So if we just release the A1 pulley, we may correct it for a while. But as that tendon passes through the superficialis tendon, we can get triggering that actually occurs there. We can't release more pulleys. We release more pulleys and we cause bowstringing of the finger. And so a novel idea which they studied in this was the release of one of the slips of the FDS. So if you imagine the flexor digitorum superficialis coming up around the tendon, it's got one slip on one side, one slip on the other side, comes around and inserts. The other tendon comes up through the middle. If we release one of those slips, then this tendon slides off to the side. And now we've avoided that through and through effect. And so it's worked very well, and all these patients did reasonably well with this. They only had one in their study that needed further treatment with that. And this is not necessarily a new technique. It's something that we've known about for a while. A lot of us as hand surgeons have used it as a revision type surgery. So if they fail their A1 pulley release, then we can go back and we can release this slip of the FDS tendon and get good results with it. This study is more recommending that in diabetic patients, we might consider doing it at the same time to prevent those reoperations. Is carpal tunnel syndrome caused by keyboarding? I think if I asked you all to raise your hands, we would have a pretty good majority that say, yeah, it can be. This was an interesting study done in Sweden. They actually sent out a questionnaire to patients. They sent out 2,500 questionnaires in a specific location in Sweden, and they amazingly had 80% of their surveys come back. And then 80% of those patients actually came in for a medical evaluation. And they separated these patients into two separate groups. One group high risk, one group low risk, or low use and high use. And I think it was greater than 4 hours of use a day on keyboard and less than an hour of use on keyboard a day. They probably should have separated it into low, medium, and high. That's kind of probably not enough, but that's just one problem with the study. And they actually had interesting results. They actually found in their studies that the patients that had less use of keyboards in the low group had a lower incidence of carpal tunnel syndrome. So that would lead you to believe that, well, keyboarding actually treats carpal tunnel syndrome. And it's not the case. The study's flawed in a lot of different ways. And so, again, you have to be very careful when you look at these studies. Population-based studies, you have to be very careful. You have to look at them over time. You have to look at your dropout rates. And so this study, while I think it is interesting, I don't think it's showing us what's really happening. And so I'll be interested to see if they actually continue to follow this group of patients and see what the dropout rates are over time. So can I answer that question for you today? Does it cause it? I can't answer it for you. I know Workman's Comp would like me to be able to answer that too, and we just can't answer it. But this is certainly a novel technique and an idea that I think somebody's trying to answer that question for us, and I hope that they will. My opinion is that we are all different. We are all individuals. And some of us are more prone to carpal tunnel syndrome than others. And depending on the job that we choose, sometimes that may increase our incidence of it actually occurring in us because of what we do. But I don't think that it has so much to do. There's certainly a lot of people that I see that keyboard that never have a problem with carpal tunnel syndrome. And then there are others that do. And so I think we need to look more at individuals and the risks in certain people. Is it hand size? Is it hand function? What are the specific things that actually may contribute more? Certainly, keyboarding can be an aggravating factor. I will agree with that. So outcomes, I will get off of carpal tunnel syndrome eventually, but this is a topic that is very common in our practice, and I know that all of you probably commonly see. So I want to talk about some of the new things in it. Outcomes. Some surgeons, I'm not one of those, but some hand surgeons prescribe therapy for all of their patients post-carpal tunnel release. And this study was a study that looked at patients that received therapy after and patients that didn't. So they randomized these patients into several groups and basically said, you're going to get therapy and you're not going to get therapy. And then they looked at them afterwards several years later to see, did the ones that got therapy afterwards return to work sooner? Did they have better function? Were they happier? And so forth. And their results basically came out that there was no difference. Some good and bad things about the study. Good, I think that they're looking at a good thing because a lot of people do prescribe physical therapy after surgery for carpal tunnel release, and then there are some that don't. So there is a controversy in the hand world with regards to this. I don't typically do it, but again, I go back to what I believe, and that is that everybody has a different makeup. And there are certain patients out there that are going to benefit from it, and there are certain patients that aren't going to benefit from it. So I don't typically do it, but the patients that are having problems or struggling, I think that they probably do. So the problem probably with this study is that they just took all comers. And you probably need to put patients into a study like that that are all more similar. Similar EMGs, similar nerve conduction studies, similar duration of symptoms, similar severity of symptoms, and then compare them. And I think that we would see different results if we did that. So that's a way to, I think, change that study and make it better. And hopefully in the future somebody will do that. This will be an interesting thing. I don't know how many of you have heard about the scratch collapse test. It's not scratching your head. I just put that picture in there to emphasize the scratch part. But this is a new test for carpal tunnel syndrome that can be used to help diagnose carpal tunnel syndrome. We do pretty good with the Tunnell's test and with Phelan's test. And those work pretty well. But this is a novel idea by Dr. Mackinnon, and I've watched her at a couple of conferences over the years show this test, but this is the first time she actually published it and actually gave a description of it and the description of how to do it and the idea behind it. The way this test is done is a very simple test that can be done in the office. The patient places their arms with the elbows flexed at this position, and then they perform external rotation of the shoulders. They do that against resistance, so you put your hands out there and resist them doing that. You do that, you resist them, you let them relax, and then you lightly scratch or touch in the distribution of either the median nerve, it can be done for carpal or cubital tunnel as well, or the ulnar nerve. So you just lightly touch it, and then you have them do the test again. And what you will see is you'll see an inhibitory effect. So when they go back to externally rotate, you'll either notice a decrease in the side that is affected, if it's a positive exam, or they'll actually fall for a second until they recover. It sounds totally voodoo, and I thought that when the first time I saw it, but it actually has to do, and she describes it well, has to do with an inhibitory effect in the nervous system, and it works quite well. In their study, they looked at the sensitivity of it, and sensitivities were in the ranges of 60% sensitive for both carpal tunnel and cubital tunnel, which you would say in your mind, well, that's not that sensitive. But when you look at the sensitivities of Tunnel's and carpal tunnel and Phelan's test, they're really only about 40 and 50%. And so this is actually a test that is probably more sensitive than the tests that we're currently using. I'm not saying that it should replace those tests, but it's another one that we can use when we have those difficult patients that don't seem to give us that clear clinical picture. It's an interesting study, and we actually, myself and Dr. Adams, have used it in our practice already quite a bit, and I'm amazed at actually how much it works. And it actually is more sensitive for cubital tunnel in their study than it is for carpal tunnel. So surgical options for carpal tunnel syndrome. One of the controversies that has been around for a while is endoscopic carpal tunnel release versus open carpal tunnel release. Endoscopic is not necessarily a new procedure. It is something that's been around for a while. There's actually 3 or 4 ways or different instrumentations to do endoscopic carpal tunnels. And early on, there was some concern that it was too risky and that there were more complications associated with endoscopic carpal tunnel surgery. This is a procedure where you make a small incision here at the wrist, you avoid an incision in the palm, an endoscope is placed, you visualize the transverse carpal ligament, and then it's cut. The idea behind this was that it's a smaller incision. We all like smaller incisions, and the idea is that the incision is back in the wrist where it heals easier and is less tender than here in the palm. There was also the thought that maybe people would return to work a little sooner, and that's really why that procedure came out and has been used fairly extensively. And Dr. Adams doesn't do it, and I do it, and there are some people here in the community that do it, and again, there's kind of still a controversy behind it. And there are still studies, new studies out that are trying to help with this debate, and this is one of them. And it basically was looking at return to work. There have been many studies looking at who goes back to work sooner, endoscopic carpal tunnel release patients or patients that have open carpal tunnel release. And there's not a big, huge difference. If you look at all the studies, there's probably 5 or 6 of them out there. This study said that that the patients went back to work about 6 days sooner than other patients went back to work with endoscopic versus open carpal. That's not that much. There's another study out there that showed 2 weeks. So is there some benefit? Are you going to go back to work a little bit sooner? Yeah. Is that a significant difference? Barely, at least in this study. So you have to take that into consideration. But it also, said that we still haven't answered the question. And I don't think we've answered the question, which is better. I don't know that there is necessarily better. Whatever's better in your hands is good, and so I think it's certainly a reasonable procedure to consider. More carpal tunnel stuff. This looks at the relationship between duration of symptoms and how patients really, before they have carpal tunnel surgery, and whether that makes a difference. If I wait 2 years before I allow somebody to have carpal tunnel release, is that wrong? Are they going to have a worse prognosis? So they sort of looked at this. Again, there are some problems with the study. They found in this study that the duration of symptoms had no effect on the results after carpal tunnel release, also had no effect on the severity of their symptoms. That's this study. Again, they're not looking at duration and severity of symptoms together. If you have a patient that comes in that has carpal tunnel syndrome and it's intermittent, they have numbness at night, maybe when they're driving, but it goes away, comes and goes, it's been doing that for 5 years, big deal. Give them the conservative treatment, and they'll probably do very well with it. However, if you have had a patient that has had carpal tunnel syndrome for 5 years, has progressively developed constant numbness, has some thenar atrophy, now that's a situation where the duration of symptoms with the severity of symptoms does affect the prognosis, does affect how soon I want to do surgery on this patient. And so that's the only flaw I really see in this, is that, again, they didn't really look at specifically the severity of symptoms, but just how long patients had those symptoms. Outcomes in conservative management. How do our patients do with conservative management? And this one sort of looked at, what if we just treat patients conservatively? How do they do long term? And what really came out of this study was the severity of symptoms. And that's what I really liked about this study, is that it came down to it depends on the severity of their symptoms. If their symptoms are severe, if they have atrophy, if they have weakness, if they have constant numbness, then those are problems that if we wait too long, then they will have irreversible damage. Whereas if a patient has intermittent symptoms, night symptoms, things that can be controlled conservatively, then it's okay for us to wait a period of time. And this is important for us because it was always difficult for me as a medical student and as a resident to decide which of these carpal tunnel syndrome patients need surgery. And that's really helped me. The duration of symptoms, I think, is important, but it's more important their severity. And that's where I think the EMG and nerve conduction studies come in, and that's why this study is important. It's because this study sort of looked at, do we need EMGs and nerve conduction studies to diagnose carpal tunnel syndrome? And this study looked at patients that had diagnosed carpal tunnel syndrome, and those that didn't, and they did nerve conduction studies on them, and they basically looked to see, is nerve conduction studies confirming our diagnosis, and are our clinical suspicions right? And they found that yes, the clinicals we do very well at diagnosing carpal tunnel syndrome in the office. The patients that need nerve conduction studies are the patients that are very odd, that maybe have whole hand numbness or proximal numbness or symptoms that don't really fit. Those are the ones that are best for it. So should we only get nerve conduction studies on those patients? And the study didn't answer that for us. But again, my opinion on that is that it's still important to get the nerve conduction studies. Again, it goes back to identifying their prognosis and also identifying the severity. Because I like to tell my patients what they can expect. You've all met patients out there that have had good results from their carpal tunnel release, and you've met people that haven't had good results. And that's a direct result of, again, patient population and how severe their symptoms are. I'll speed through this. Complications. This was a study that looked at complications because that was one of the early concerns of endoscopic carpal tunnel release, and they thought there were more complications. This looked at all the articles on endoscopic and open carpal tunnel release and actually found more complications with the open procedure. So the disasters don't only happen with endoscopic, but they actually more commonly in this study happen with open. Return to functional use. This is sort of similar. I'm going to skip by this because I'm running out of time. But metacarpal fractures, this was kind of a novel study that looked at boxer's fractures, something we commonly seen. As a resident, I hated these. I'd have to go in at 2 in the morning, give a hematoma block, reduce it, and put it in a cast. And this study basically looked at all comers, all fifth metacarpal fractures. They divided them randomly, half and half got a cast reduction, and the rest got buddy taping and said, if you don't have a problem, then don't come back. They brought them all back in 12 weeks, and there was absolutely no difference in their functional outcome, and the ones that actually had buddy taping were actually happier with the result because they didn't have to wear the cast. And so it kind of shoots you in the face about the treatment of fifth metacarpal fractures. I'm not advocating that we don't treat fifth metacarpal fractures. Again, I think there's an issue with patient population. I don't know if they were looking at displaced fractures that were comminuted. I don't know if they had how much angulation they had. There's not specifics about those things in that study. So this isn't really going to change my practice until I get more specifics. I'm going to skip arthroplasty. Dupuytren's contracture. This is something that's fairly commonly seen, but this is something that's new that's coming out that I want to talk about. There's a new substance, collagenase substance, that is being studied actually here in the U.S. now. It's been used for years in Europe. And it's a material that is secreted by cells, and it basically melts the surrounding tissues. This substance has been being injected into cords and nodules of Dupuytren's contracture in Europe. They inject it, it melts the cord, they come in a couple days later, manipulation is performed, and the contracture is released. The reports out of Europe are very good, so much so that we've started to study it here in the United States and are now in phase 3 studies. So we can expect probably in the next 3 to 5 years that we'll actually have the opportunity to probably use this medication. There are some complications that have been studied out there. Obviously, it doesn't selectively melt fibroblast contraction bad material. It can melt tendons, it can melt arteries, it can melt nerves. So we have to be careful where we inject this clearly. And it's not just a simple answer that we're going to have an injection that cures this disease, I don't think. But this is something that is exciting for us. I look forward to possibly being able to use it, and it's something that's on the horizon. Another thing that's being used in Dupuytren's contracture, because right now, most of you know, the treatment of this is fasciectomy. Make an incision from all the way one end of the finger all the way down into the palm, and you take the tissue out. And that's not curative because this is a genetic disorder. So it's a hard disease for us to treat because the surgery is big. It takes a while to heal from, and it needs a fair amount of therapy. So it's not an easy thing for us to treat. This is a new technique that, again, is just with an injection. You basically put a large bore needle in, you move it up and down, and you use that needle like a knife to cut the cords and nodules. A lot of people in Europe are using this, and there are some people in the community that are using this now. I currently don't use it. I didn't receive a lot of training in it, and quite honestly, it scares me. One of the things that happens in Dupuytren's contracture is it withdraws the bands, the neurovascular fibers, it draws them centrally. So if you just go in there and start willy-nilly cutting these fibrous bands, you have, I think, a great potential to cause a neurovascular injury. And I'd rather see it with my eyes so that if it does happen, I can repair it. So I still like the open procedure, but this is something that is being used that you'll hear about and that patients ask about. The last thing with Dupuytren's contracture is this metalloproteinase stuff, and I think that this is an exciting thing that's coming on the horizon as well. This is an injectable material that is made by cells that they actually inject into the nodules, into the cords, and so forth. And it has an inhibitory response on those specific cells, the fibroblast cells. As we know, the fibroblast cells in Dupuytren's contracture cause a contracture of that tissue, which draws the fingers down. And if we can inject this stuff early on in the course, or if we can inject it at the time of complete fasciectomy, then we have the potential of preventing the contracture from occurring or recurring. Again, it's not available to us yet. It's on the horizon, but it's showing promise. They've used it in canine cells so far, and hopefully we'll be using that soon in humans to see how that works. Sorry, I had too much here. Vasospastic disorders, this is something that you might see patients with Raynaud's phenomenon. This is a new, novel idea that we're actually using in our office, and it's the injection of botulism toxin. We used to do a surgery, and I still do this fairly often, but it's called the sympathectomy. It basically takes the nerve fibers off of the surrounding vasculature and causes them to dilate to get better perfusion to the fingers and prevent them from vasoconstricting. Botulism basically paralyzes the nerves, or paralyzes the muscle, as we know from a lot of the plastics literature. So we're now injecting it into hands around the vessels, and this causes a paralyzation of the muscle fibers in the vessels that causes dilation. We don't know how long it will work. Again, usually you need multiple injections with many of the other things that we've used. And so this is something we're using. They're allowing us to use. It's hard to get covered by insurance, so patients have to pay for the botulism themselves, and then insurance will actually pay for the procedure to inject it. But we've seen pretty good results in the literature and also in our practice. We just don't know long-term whether this is going to need multiple injections or not. The last two slides have to do with tendon healing, and basically one of the things that plagues us as hand surgeons is tendon repair. Tendons are their weakest at 3 weeks after repair, and a lot of times at that point we see ruptures depending on how we repair it. So we've tried to use different kinds of suture to hold the repair strong while it heals. This new idea has actually come up with cells that are derived from embryonic cells that secrete the tissue healing factors for tendons. The problem is that we can't just squirt it on the tendon because the body washes it away. It has to stay there long enough for it to cause an effect. So one of the things that they have now done is they have bonded these cells to suture material, so that when we repair the tendon, that stuff is in the suture material and helping cause repair of the tendon. It's not available to us yet. Again, it's on the horizon. It's one of these things we're looking forward to. There's another one, and that's in this, that is actually derived from platelets, and they've created some kind of a glue that they put these cells in that we can squirt onto the tendon, and it glues it there and holds them there so that they can have their effect. So those are things on the horizon that we hope we can use that will be beneficial to our patients and provide them with lasting effects. Again, thanks for the opportunity to talk to you. I hope these provide you with some information about hand.